Okay, I think we'll make a start. I'm conscious that I stand between you and the lunch break, and we want to make sure we don't delay getting there. So thank you to Karen and the organisers for inviting me to talk to you today. As has been said, I'm James Davison. I'm a metabolic paediatrician based at Great Ormond Street in London. And I've been asked today to talk about newborn screening and where we're up to, particularly about ALD, but also thinking about some of the other leukodystrophies, and we'll talk a bit about the where we're up to for screening for metachromatic leukodystrophy, MLD, as well. So this, I'm sure, will be familiar to many of you, but just to first of all ask the question, what do we mean by newborn screening? It's something that Dr. Malak had mentioned about. And essentially, newborn screening is doing things to try and pick up some of these rare diseases that we've been talking about early before they cause symptoms. You'll be familiar with the heel prick test that babies have when they're 5 days old. That's the main thing we think about when we think about screening. But actually, in the context of the NHS, there are other components to what's done to see, can we pick up issues for babies? So all babies are offered a hearing test, so they have the newborn hearing screening. They also have a physical examination by the doctor or the midwife looking for other issues like hip problems. So there are different components to the newborn screening program in the NHS. And the whole purpose of the screening, as the NHS website states, is that the purpose of the blood spot screening is to find out if your baby has any of a number of these rare but serious health conditions, and importantly, then we can step in with early treatment to improve the baby's health. That's the rationale for why we do it. What do we screen for at the moment with that heel prick test? Well, we've talked about many of the different disorders, but actually there are only a limited number that we are testing for on that heel prick test currently. So we look for certain blood diseases like sickle cell disease, cystic fibrosis that can give risk of recurrent chest infections, thyroid problems, severe combined immunodeficiency, so severe immune problems, and some regions are also testing for SMA, spinal muscular atrophy. And then when we think about the metabolic disorders, the area that I work in, there are these conditions that are on the panel. The bottom one there, hereditary tyrosinemia, which causes a liver disease, is actually just being added to that testing panel and is due to go live in the next week or two. So that's just being added on as a new disorder. And if we think about, of those conditions, these are all rare disorders, how many might we expect to pick up? How many babies are picked up each year with these conditions? Some of them are relatively common for rare diseases, so we maybe have 200 or 300 babies a year who are picked up who have cystic fibrosis, for example, or some of the thyroid problems. When we look at the metabolic disorders, those are rarer. PKU and MCADs, two conditions we look for maybe 70 or so babies a year, but the others, you can see we're down to very small numbers being detected. So the program is set up to pick up some of these very rare disorders, and just because there's only a very small number doesn't make it any less important that we are looking for those. But as we've said, this is only a small number. This is, I don't expect you to read it, but this illustrates that there are hundreds, thousands, more than 1,000 inherited metabolic disorders that we are aware of, and we're screening for a tiny fraction of those conditions. So the question is asked, should we screen for more of those? Can we be screening for more of those conditions? Where do we sit in the UK if we were to think of it in terms of the European League table? We're kind of mid-table at the moment. I don't know which football team that's analogous to, but we're well below many other countries in terms of the number of conditions that we're screening for in the UK. So who decides what we screen for when we're thinking about which conditions go onto that screening panel? The screening programme in the UK is overseen by the UK National Screening Committee, who make recommendations to governments in England and the devolved nations for what should be on that panel. They have a process, and there is a process for annual topics to be suggested to the screening committee to consider. They have specific criteria that we'll look at, which they consider to decide if a condition should be on that screening panel. And for a condition that gets proposed, if it's not accepted straight away, there's a review process every 3 or 4 years. And sometimes, as we'll see, they will also go to public consultation. So what are the criteria that they would think about? How do we decide which of these hundreds, thousands of conditions should we be screening for? And there are different things that they would look at. They would look at the condition itself. Is it an important condition that we need to be helping with? Is it a severe disease? How frequent is it? And so on. There has to be a good test to be able to pick up the condition, and we'll talk a bit about that. But also, importantly, you've got to be able to do something about that condition once you've found it. So is there a good intervention, a good treatment that you can put in place to improve the outcome? And there are other aspects that they look about how a screening program would work and how it's implemented. When we think about that important question, we may have a condition that we want to be testing for and identifying and diagnosing, but actually there's a fundamental question: is there a good test to actually do it? Is there a way we can do that? If you think of it a little bit like a car alarm, you want a car alarm to work well, and there's 2 different things you would like your car alarm to do. You want it to be a sensitive car alarm so that it will go off. You want the car alarm to go off every time a thief tries to break into your car. You don't want it to only work half of the time whenever sort of 50% of the thieves breaking into your car. And that describes what we call the sensitivity of a test. You want the test, if we think about ALD as an example, you want it to pick up every child who has got ALD. You don't want to miss any. But you also want that test to be specific. So sometimes car alarms go off and it's not a thief breaking in, maybe a bird's landed on the roof, and you want the test to be specific. You only want the car alarm to go off when it's that thief trying to break in and steal the car, not when the bird has landed on the roof. And that refers to the specificity of the test. We want the test only to detect children who've got the condition we're interested in, and not, for example, flag up a result when it's actually a healthy child or a child who's got a different condition. So how specific is the test? And there are other things we would also think about in terms of evaluating the test, but those are some of the important things. We want it to pick up all of the children affected, but only those who've got the condition and not other things as well. So let's just have a think about ALD, adrenal leukodystrophy. Do we think this is an important condition? And I think I don't need to persuade you to understand that, yes, this is a really severe condition. We know that if we knew a baby had ALD or a child has got ALD, we could be looking out for the severe consequences. We could be monitoring for the adrenal insufficiency, start treatment if that emerged. We could be, as Dr. Malak has also explained, be monitoring for the brain disease, looking out for those very early signs so we can step in with the different treatment options. So it's definitely something we would want to know about. But there are some questions that we still have to be able to answer. Do we know how many babies we would expect to be born in a year with this condition? This is the sort of information that the screening committee want us to have so that we can show kind of how the program would work. And one of the challenges is, do we know who is likely to get adrenal insufficiency or cerebral disease? And actually ALD is quite hard because it's quite unpredictable in terms of when those things are going to happen as well. So there are some complexities around the condition that we don't have all the answers for. Do we have a good test for this condition? Well, the experience we've heard from others is that we do have a specific test that can be used in newborn screening to pick up babies who've got ALD. The C26 lyso-PC is the chemical that is measured in the blood spot, and Stefan Kemp, who's here, has set this up and established the work in the Netherlands. So there is a good test that has been established that can pick up these babies who've got the condition. You need other things as well, though, because we want it to be sensitive, so it picks up all the babies, but only babies who've got ALD. And so the program, the protocol has also got to establish that it's not being caused by another condition that you don't want to be picking up. But I think there is a good test for ALD that's available. Do we have a good intervention? We've just been hearing about the treatment options. So we know that if we can pick up the brain disease, that we can step in with a bone marrow transplant. In the UK, that's our only treatment option at the moment for brain disease. We don't have access to the gene therapy. But we know that if we find the adrenal insufficiency, that's also important and we can step in. and treat that. Some of the questions we still have and some of the things we're looking at are making sure we've got very clear pathways so that we know who we need to monitor, how often we need to do the scans, and we need to have agreed protocols for who we need to treat and when do we need to do that. So I think there is good evidence that the treatment is working and is there. The current situation, as we've heard from the UK National Screening Committee, is that screening for ALD is currently not recommended. So we haven't persuaded the NSC that there is enough evidence for all of those questions, and there is some work going on to put in some updates to that evidence to try and show that actually we think the situation may be in a different place now and can move on, and we'll come back to think about what next a little bit later. A bit more briefly, MLD, metachromatic leukodystrophy. This is another one of those inherited white matter disorders we've been hearing about that causes progressive childhood dementia and is a very severe form of the leukodystrophies that will cause early death in many patients. This is one condition for which we do have access to the very effective gene therapy, but as we've heard, you've got to use it at a very early stage. And actually, for most babies or infants with this condition, it has to be given before the symptoms have actually come to light, so in that pre-symptomatic phase. So the only way you're going to know a child has got the condition is either if there's been another family member, an older brother or sister who's been affected and you've then tested a younger sibling, or if you're doing newborn screening. So it's a very important condition. We've got a treatment that is available and funded by the NHS, but we need to be able to pick up those babies. Is there a good test? And this is work in progress. It's a bit more complicated for making these sorts of diagnoses, but there are established tests available for screening for MLD, measuring something called the C16 sulfatide and also measuring the enzyme activity in the blood spots. So there is a good test that's available. Currently still, we don't have approval for screening for this condition. It's not recommended by the NSC, and I'll mention about a consultation that has been recently undertaken about that. Just a word about another direction for newborn screening, so the generation study. This is something some of you may have come across or heard about. This is a research study being run by Genomics England, and this is aiming to look at whether using a different way of screening, using genetic testing rather than measuring chemicals, could be useful and could it be implemented in the NHS. There are different components to this research study. One part of it is the newborn screening, but it's also aiming to establish data from 100,000 healthy newborns having their genome data collected and then linked in with their health records going forwards to provide a repository for researchers. So there are different components to this. It is reporting about 200 different disorders for those who take part in it, and it includes the genes that cause ALD and MLD, as well as about 90 other inherited metabolic disorders. So that's ongoing. I think time will tell how effective or not that is, but that's just to be aware of that. But that is a research study. It's not mainstream policy at the moment. So what happens next? For MLD, I mentioned there was a recent consultation undertaken by the National Screening Committee that a number of professional groups, some of you as families may have also put in contributions to that consultation. I know that Alex TLC have also contributed feedback to that, and we're waiting to hear again back from the NSC what their response will be to that and where MLD screening will go. In terms of ALD, there's an opportunity to put a submission into the NSC that Alex TLC is looking at in terms of giving an update on the evidence that we have. The last review by the NSC for this condition was undertaken about 5 years ago, and there's been a lot of progress since then, and I think we need to make them aware of that. And also, there's work going on between the groups, the professional groups, agreeing the care pathways that we need to have in place if we were to have screening available. I think it's only fair to say the National Screening Committee are open to further expansion. We've seen that tyrosinemia has just been added onto the panel, and there is certainly a move towards an openness to considering other conditions to be added on, and we're keen to collaborate in that work. And then also, just to throw a bit of UK politics into the mix, we've recently had the latest NHS 10-year plan published by the government, and this includes, one of its aspirations is to offer universal newborn genomic testing as a means of doing newborn screening in the next 10 years. So this is in there. It's an aspiration, and it may perhaps cause a little bit of distraction from other areas of the trying to expand newborn screening. So I think we need to see where that goes. Just a comment on this. Do we want to do newborn screening by doing genetic testing, or do we want to do it by biochemical testing, measuring chemicals? And when we're thinking about how effective a test is, thinking back to that sensitivity, specificity question, I think genomic testing might not be as sensitive at picking up specific metabolic conditions, because we don't have all of the details about which genetic changes are important. Sometimes there are some other complexities. So I think there are some concerns that doing genetics only is not going to be as good for any individual disorder. We also know that currently genomic testing, although it's getting quicker, is still a slower process than doing the biochemical tests. And certainly for some conditions that we're screening for, we want to know about it within 24 hours of having your screening test, because we know there are some urgent treatments we need to do, and genetics is just too slow for that. Genetic testing is important as part of the whole diagnosis for any rare disease, and I think we just need to have a very careful consideration as to how those are combined, and not throwing the baby out with the bathwater, as it were, when we think about biochemical testing. And we need really that combination of both genomic and biochemical screening. So I'm going to draw things to a close there. Hopefully that's just given you a little bit of a flavour or an update as to where we are for testing. Currently we're not screening in the UK in the standard screening for these rare leukodystrophies. There are moves afoot to try and move that process forward, and we will see where we get to. But I think we all agree that it is important that we are able to identify these conditions and avoid that diagnostic odyssey, and avoid the situation where we make a diagnosis and then have to sit down and have that conversation to say we're already too late for us to intervene and to make a difference. So I'll stop there, and happy to take any questions.
Thank you so much, James, and thank you for all the work that you're doing to help us both with ALD and MLD. You know, we started trying to get screening for ALD in 2016, and if it hadn't been for all our wonderful doctors helping us, you know, we wouldn't be where we are. And yeah, we're looking at adding some more information, and hopefully we'll have better news soon. I don't know if anyone's got any questions. Yeah? Sorry, making Steve work now.
This might be slightly off topic, but as a parent of like a child with a rare disease with no cure, no treatment, nothing, I'm wondering what's the direction of like prenatal diagnosis and screening? Mm-hmm. Is there any development there? Is that something that will become a bit more standardized, like the newborn screening?
Yeah, thank you. So I think if we have a family and if a diagnosis has been made in the family, or we know that parents perhaps are carriers for the condition, so there's a risk of a baby having the condition, the colleagues who work with the clinical genetics service would be able to talk about options that families have for testing. So if we know that there's a genetic diagnosis, some families, some parents may choose in a future pregnancy to have testing done at an early stage of pregnancy. So that is possible if there's a known condition. There are also some situations where it's possible to do the testing even earlier with pre-implantation genetic diagnosis, so a form of IVF, in vitro fertilization test tube baby, where you do the testing early before the embryo is implanted. So those are some options for families where there's a known diagnosis. Some families would be offered that and choose not to, and then we would put in place a plan for testing once the baby's been born, and sometimes putting in place treatment plans while we're waiting. So there are options that are there, and for any families who want to explore that, it would be very much asking for the clinical genetics teams to be involved. Thinking more broadly about doing screening when you've got a mum who perhaps is pregnant, who there aren't any specific concerns, that's not routinely offered. Occasionally, families have undertaken testing, and there are some private laboratories that might offer testing for a baby. That's really challenging because sometimes it throws up things you're not expecting or things that aren't clear. Sometimes on another scenario is a mum is pregnant and the scans have been done during pregnancy. They've shown some concerns. Maybe there's excessive fluid build-up in the baby or something, and that has then led on to a question, can we make a diagnosis? And in that situation, there is the possibility of doing very broad testing, whole genome or whole exome sequencing for the unborn baby. And there are some particular genes that we would look at, and sometimes we have then made a diagnosis in that situation as well. And that can be helpful because we then understand that there may be different avenues for treatment options or how we look after the baby. So I don't know if that answered the question from the angle you were coming at, but there are these different aspects to it.
I was wondering if this, like, in ideal future, prenatal screening for like a wide range of conditions would be an option.
Yeah, I mean, that's one future possibility. At the moment, we're very much focused on the newborn screening. Yeah.
Sarah has a question. Sorry.
Getting the steps in, running around.
So I'm going to say when rather than if we do get ALD and MLD onto the newborn screening programme in the UK. What is the process once that decision is made? How long do we have to wait before we see it actively happening?
It's a very good question. So I think if there was a decision by the NSC to recommend it and it was then taken up, they make a recommendation to governments, and if the minister says yes, that's good to go, it is then quite a process for actually getting from that decision to go live. If we look at the tyrosinemia condition that I mentioned, the decision from the minister to go live with that was taken March 2023, and here we are 2 and a bit years later, just about to go live. There's a lot involved. In one sense, it's simple. We say we just want to add this test on, but actually, all of the logistics, all of the laboratories that process those heel prick tests from the babies all have to have their equipment updated. The relevant tests have to be loaded onto the system. It's not a simple thing. One of the benefits of the tyrosinemia being added on is that all of the screening laboratories, and there are 13 across the UK, are now using the same test kit system, so there's been a uniformity of that. That system covers all of those conditions I've mentioned that we're screening for, but has also got other conditions already sort of ready to be plug and play, if you like, loaded on. So they're, in an optimistic sense, if these conditions were given the go-aheads, that some of those barriers to achieving the rollout perhaps has moved on. There are still other things there, but I think if there was a thumbs up from the government, it would probably be 18 months, 2 years before we actually got to the point of go live. So it's a timeline still.
Thank you, James.
Okay, thank you.